Good morning. New topic, new week. We'll be discussing this week chest pain. The learning outcomes for the next 4 to 5 lectures would be as follows. Define chest pain. List the various diagnostic triads. Describe the key features of each of the diseases that are covered in the diagnostic triads. Review the labs mentioned in these diseases and review the significance of specific directly or indirectly mentioned physical signs. Our index patient is Ignatius Michael N. Payne, Uncle Iggy, to Brian and his family. He lives in Vermont and suffers from intermittent chest pain. That was worse last winter when he was shoveling the snow dumped on his driveway by the Arctic blast. If you look at the name, looking at the letters or words in red, you will see, pun intended, I am in pain. Haha. Okay, I will stick to my day job. Chest pain is defined as the sensory response to noxious stimulus by either trauma, dysfunction of the chest wall, heart, lung, esophagus, or diaphragm. The distribution of chest pain, which is a common complaint in the American population that goes to see primary care physicians, nearly 40% of all chest pain is chest wall issues. 20% is gastrointestinal, a similar 20% is cardiovascular, 10% is pulmonary in origin, and 2% is none of the above four groups. Other involve structures. From a perspective of pain generators, we're using the same Murphy's approach where we're going to go through the first couple of diseases which are red flag situations, and if there are no red flags like chest pain associated with sweating and you've ruled out pulmonary embolism, myocardial infarction, and dissecting thoracic aorta, then the Murphy's model suggests that the next question we go to is, what's the source of the pain? Now, the source of the pain in chest pain could be, as I said, either chest wall, gastrointestinal, cardiovascular, pulmonary, or others. So if we look at chest wall pain, the pain chemical or the chemical mediator for the pain is bradykinin. And what typifies chest pain that is chest wall in origin? The pain is sharp. It is worse with movement of the trunk, especially the thoracic part of the trunk. Gastrointestinal pain, things like GERD. The chemical mediator for the pain is hydrogen ions, which are then going to be attached to hydrogen ion receptors in the free nerve endings of nerves that are responsible for carrying nociceptive impulses from the periphery through the spinal cord to the brain for interpretation. GI type of chest pain is described as burning pain, usually retrosternal, which is part of the anterior portion of the chest. This burning pain is worse on lying down. Cardiovascular pain, which is classically described as squeezing pain that is worse than exertion. The chemical mediator is adenosine, one of the byproducts of the breakdown of ATP. For pulmonary chest pain, the chest pain is sticking in nature and it's made worse with breathing deeply, coughing, or sneezing. And the chemical mediator is bradykinin. And others, specifically if you have chest pain that is related to panic attack or T4 syndrome, the genesis or the generator of the chest pain may involve the sympathetic nerve being dysfunctional. Any questions at this stage? Remember, you're not going to be tested on the pathophysiology, but you could very well be tested on the chemical mediator for the various varieties of chest pain from an etiological perspective. So the first diagnostic triad that is a red flag situation is chest pain associated with sweating. There are three main causes that are, should you consider these? These are 911 situations. Pulmonary embolism is the first. There's an asterisk, a red asterisk next to that. Remember, this asterisk implies that we've done this before. Pulmonary, so I'm just going to review the highlights. Pulmonary embolism is a blood clot that has gone to the lung. 98% of all PE is derived from deep vein thromboses in the leg or the pelvic veins, and it could be associated with one of the following parts of Virchow's triad: hypercoagulability linked with oral contraception, leg injury, or immobilization causing stasis, either seen with recent long travels lasting more than 4 hours or hospital immobilization for various reasons. Clinical picture for pulmonary embolism is the classic triad of sudden onset of shortness of breath, hemoptysis, and pleuritic chest pain. That's a 911 call. When they get into the hospital, there's a protocol. Blood would be drawn for D-dimer. D-dimer is a good screening test. That if it is positive, it says that the cause, if this is pulmonary embolism, is related to a clot. But remember, if the D-dimer is negative, then it doesn't mean, if it is negative, then it means definitely you don't have a clot from which the embolism has been generated. The definitive tests would be either spiral CT scan or a ventilation perfusion known as a VQ scan or a lung scan. The spiral CT scan is without contrast and therefore it is a non-invasive test. And the ventilation perfusion, the VQ lung scan, is an invasive test where you inject a small amount of a radioactive material and you scan, take a picture of the thoracic region looking for a defect in the distribution. Myocardial infarction is the next 911 call situation for a patient with chest pain associated with sweating. Myocardial infarction is defined as irreversible ischemic damage to the heart. The most common cause is atherosclerosis affecting the left anterior descending branch of the left coronary artery. And the clinical picture is sudden onset of severe squeezing retrosternal pain with sweating and a feeling of impending doom. Again, you hear that. No examination is needed at this stage. Don't waste time checking the blood pressure, checking the pulse, doing your vital signs, weighing the patient, etc., looking for a subluxation. This is a 911 call. Wait for the ambulance to get to your office. While they are in the ambulance, they are going to set up a 6-lead ECG instrument looking for specific changes that are diagnostic of the most common type of myocardial infarction, which is called STEMI. And then they will take blood, but they don't have the facilities to analyze the blood in the ambulance. They would already take blood, and when they hand the patient over to the ER personnel, then they pass the blood on and the results of the ECG. Sometimes, though, so what I've just described for you is the classic presentation, retrosternal squeezing pain. They often put their hands over the left side of the chest. This is classic. Sometimes it is located under the sternum in a larger area. Sometimes it goes up into the neck, often into the left side of the jaw, and down into the shoulder and along the inner aspect. Let's use the pointer to show you. Going up into the left side of the jaw, down the arm and along the inner aspect of the left arm. Sometimes it is in the epigastric region. Sometimes it is going to affect the other side, the other shoulder. Sometimes it's the back that they perceive the pain somewhere in between the scapular blades. Other uncommon myocardial infarction presentations would be in females. Females have a tendency of not describing retrosternal chest pain that is squeezing in nature. They're more likely to describe feeling of indigestion, intense nausea. They may become acutely short of breath, and this is because of the difference between males and females as to the extent and distribution of the atherosclerosis. Atherosclerosis in males tend to pick out the left coronary artery shortly after the left coronary artery divides into the left anterior descending and circumflex arteries. In females, it's not the first inch or so after the bifurcation. It's the entire branches of the left coronary artery that are affected. And then you have the situation with the patient with diabetes mellitus, often type 2. This will cause a silent infarct. They would not be aware that there is chest pain. They may not appreciate any indigestion or nausea. They may not present with sweating. And this is because in some patients with not properly treated diabetes mellitus, there is autonomic neuropathy. The nerves that carry the nociception from the heart to the spinal cord up to the brain are the postganglionic sympathetic fibers from T1 through to T5. And if these nerves are damaged, then they could die from a heart attack and not even be aware that they're having a heart attack, so they wouldn't be able to call 911. Here are the ECG findings. If this is found within, if the ECG is done within the first 10-15 minutes of the onset of the myocardial infarction, you would have hyperacute T waves. Here's the normal T wave, short, positive, bump. Here is the hyperacute 2 to 3 times the normal T wave. And then the first one that is often seen when they get to the hospital is the ST elevation. ST segment should be over here. That segment has gone up like that, so there's ST elevation. This is followed by T wave inversion. The T wave should be going up positively. It is going down. That's a negative deflection. And later on, as the myocardial infarction progresses and there's actual necrosis of the myocardial tissue, you are going to see deep pathological Q waves. Here's the normal Q wave, a very short negative deflection after the first positive deflection above the isoelectric line, which runs across here. This is deep. This is 2 to 3 times the normal depth. And as the patient recovers over the next couple of weeks and months, what happens is that the ST elevation returns back to normal. The T wave inversion will eventually go back and be everted, like here, And the only thing that is left as a permanent marker that you've had a problem with your myocardium within the last year is a persistent deep pathological Q waves. Another condition that could present with looking very much like myocardial infarction is the Takotsubo cardiomyopathy, also known as the broken heart syndrome, now known as the stress-induced cardiomyopathy. It mimics myocardial infarction with ST elevation, T wave inversion, and elevation of your cardiac enzymes, which would include elevation of troponin, INC, elevation of CKMB, creatine kinase, myocardial band, and elevation later on as the myocardial infarction evolves, an increase in the lactic acid dehydrogenase enzyme. Takotsubo or stress-induced cardiomyopathy is triggered by acute emotional or physical stress. This leads to transient left ventricular dysfunction. However, when the intervention cardiologist on duty does coronary angiography to determine which of the blood vessels, whether it's 2 or 3 or 4 major blood vessels in the coronary arterial system are occluded. In Takotsubo cardiomyopathy, coronary angiography would be normal. Ventrillography is diagnostic. You inject a certain dye into the system, and the dye is then picked up on a special X-ray, and it has this shape of the left ventricle. It's a globular shape with a narrowing up at the top, and that particular shape, which is diagnostic on X-ray, actually looks like the octopus trap or pot called a takotsubo in Japanese, where the Japanese fishermen would put rotten chicken feet or parts at the bottom of the trap. The octopus will then go in head first to find and eat the bait and can't come back out, and this is how they trap the octopus in Japan. A discussion on angina pectoris must happen at this particular stage. Think of angina pectoris as a forewarning of if you don't do anything about this particular condition, one of these days you will drop down dead from a myocardial infarction. So angina pectoris, angina, pain, and pectoris, chest. So this is squeezing chest pain in the chest. Think of this as a heart attack waiting in the wings. Unlike myocardial infarction, which is defined as irreversible ischemia, angina pectoris, the ischemia is reversible. So you're not going to get any signs of myocardial death. You're going to get signs of myocardial ischemia. Again, the most common cause of angina pectoris in America would be atherosclerosis, but uncommonly severe anemia, a very tight aortic stenosis, or hyperthyroidism can result in angina pectoris, which clinically presents with squeezing precordial chest pain that is worse with exertion but relieved by rest. If you or anybody in your family has been having chest pain over the heart, that's the precordium or retrosternal area, and it lasts more than 10 minutes after they sit down and hope that the pain would disappear, that is time to call 911. Don't wait for 30 seconds because time is of the essence. The earlier you can make the diagnosis, if this turns out not to be angina pectoris but myocardial infarction, the greater is the chance of this patient surviving with the proper intervention. ECG changes during the actual angina episode is going to be showing ST depression. If it is taken in between when the patient is at rest and no longer is suffering from cardiac ischemia, then the ECG is normal. So what needs to be happening is that the patient should be co-managed. You're going to refer this patient to a cardiologist. The cardiologist is going to do a number of tests, including a stress ECG, where they put the patient under physical stress. In my days, they used to hook up the patient to a ECG machine. They have them on a treadmill, and they would ask the patient to walk briskly for the next 5, 10, 15 minutes until ischemic episode is induced, and then you stop the exercise. Today they don't do that. They put the patient on the examination table. They inject the patient with a chemical substance which causes the heart to race as if it is undergoing physical stress, and the ECG changes. If this is angina pectoris, it's going to be monitored on a monitor by the bedside. So that is the nature of the ECG, the stress ECG. Concomitantly, cardiac panel or your lipid panel should be ordered, and you're looking for in particular not only a raise in the cholesterol in your blood, so hypercholesterolemia means raised cholesterol in the blood, but you're looking specifically for an increase in your LDLs, your low density lipoproteins, which are one variety of them, the dense low density lipoprotein cholesterol is atherogenic. They're the ones that are associated with atherosclerosis. If your HDLs are increased, then HDLs are cardioprotective. So co-manage with the cardiologist. You may help the cardiologist in getting home the message of you need to lose weight, you need to watch your diet, you need to exercise, and stop smoking or drinking alcohol. Here are the ECG findings that are typical for angina pectoris. ST depression. This line here that I'm running my cursor through, this is called the isoelectric line. The first positive deflection is your P wave, the first negative is your Q wave, the second positive is your R wave, the second negative is your S wave, and then the third positive deflection would be the T wave. And this portion here is usually in a straight line, and this ST segment is depressed. It's going in the opposite direction to ST elevation, which is classic for myocardial infarction. The other cause of chest pain with sweating and a feeling of impending doom is a dissecting thoracic aorta. This is defined as a tear in the intima in the thoracic aorta. Sometimes it occurs in the ascending part of the thoracic aorta. Sometimes it occurs in the arch of the aorta, and rarely does it occur in the descending part of the thoracic aorta after the ligamentum arteriosus is found. Causes: hypertension, Marfan syndrome, tertiary syphilis, which causes a chronic aortitis with a classic tree bark appearance because of the chronic nature of tertiary syphilis, or a congenital condition, meaning you're born with this, where there's a narrowing, usually beyond the arch of the aorta, commonly beyond where the ductus arteriosus is going to be present. Clinical picture of a patient with dissecting thoracic aorta: sudden onset of underlying tearing chest pain, to distinguish this from squeezing chest pain, which is characteristic of myocardial infarction, and sticking chest pain, which is characteristic of pulmonary embolism. So tearing chest pain, sweating, and a feeling of impending doom. You hear this triad or elicit this triad in the history, this is a 911 call. When they get to the ER, they're going to order an urgent CT scan or a chest x-ray, and what they're looking for in the chest x-ray is widening of the superior mediastinum. This is what the widening of the superior mediastinum looks like. I am going to draw the outline of the cardiac silhouette. This is superior vena cava. That there is right ventricle. Inferior vena cava here. Inferior border of the cardiac silhouette is right ventricle. That's the apex of the heart. Left ventricle, left atrial appendage, pulmonary vessels, and then you have a huge aortic knuckle. The aortic knuckle at this stage should be something like that. And then the diameter or the width of the mediastinum would be there. And the width in a patient with dissecting thoracic aorta is greatly increased. So that is widening of the mediastinum, which is classic for dissection of the thoracic aorta. Any questions? If there are no questions, let's go to the next diagnostic triad. And this diagnostic triad is also a red flag situation. Chest pain associated with fever, you make the diagnosis and you manage the patient properly. The first cause of chest pain with fever is pneumonia. We've already covered this before when we discussed shortness of breath with chest pain in last week's work. Just to highlight the main findings in chest pain associated with pneumonia, there is fever, and as a result of the fever there's going to be tachycardia. There are going to be crackles heard best on inspiration when you put your stethoscope over the affected area. There's going to be increased tactile fremitus and increased vocal resonance, and then there's going to be agophony, bronchophony, whispered pectoralgiquy. Labs, if done in this patient, will show leukocytosis in the complete blood count, and depending on whether this is bacterial, if it's a bacterial infection, usually Streptococcus pneumonia or Klebsiella pneumonia or Staphylococcus aureus, in addition to the increased white blood cell count, there's going to be a neutrophilia. If this were a viral infection, whether it be associated with RSV infection, mycoplasma infection, or COVID-19 infection, the leukocytosis will be accompanied by a lymphocytosis. X-ray will show the classic wedge-shaped consolidation seen best on the lateral X-ray. And remember, you need to determine, is this patient going to go to the hospital on an urgent basis or going to see a medical doctor for a course of antibiotics if they confirm that this is pneumonia. Then remember the CURB 65 criteria. See for confusion. They can't say exactly who they are. They don't know what time of the day it is. They don't know what day and month it is, and they can't remember who is the President of the United States. U means elevation in the urea. R is for a respiratory rate greater than 30 breaths per minute. B is for blood pressure lower than 90/60. And 65 is if they are 65 years or older, they should be hospitalized. Pericarditis is another cause of chest pain associated with fever. The definition of pericarditis obviously is inflammation, itis of the pericardium. Commonest causes would be viral infections, especially the Coxsackie B family of viruses. It could follow after a myocardial infarction, or it could be associated with kidney failure. otherwise known as uremia. The clinical picture of a patient with pericarditis is usually a young adult with sticking precordial chest pain that is worse on lying down, better sitting up and leaning forward. This is classic for pericarditis. Sticking precordial chest pain, worse lying down, better sitting up and leaning forward. Should you suspect as a primary care physician the presence of a pericarditis, refer the patient to the hospital. They would take blood off to confirm that there is an infection. So labs would include CBC. They would order an ECG as they are admitted, and they will see ST elevation and T wave inversion, looking very much like a myocardial infarction. However, pericarditis is not going to present with squeezing chest pain, but with sticking chest pain. Myocardial infarction is unlikely to present with fever. Pericarditis more likely to present with fever. And when you take blood for your cardiac enzymes, you will find that pericarditis, the cardiac enzymes troponin, CKMB, or lactic acid dehydrogenase are all going to be normal as opposed to elevated in pericarditis. So here is the ECG finding. So this is slight elevation of the ST wave. In this particular one, the T waves are not yet inverted. That might come in the next couple of days. And remember, I said to you that this line here, where is my marker? This line here is the isoelectric point straight across there. I can't get that. Is there another way I can do this? That would be the isoelectric point. Anything above that is a positive deflection. So if you look at this, you will see if that's the isoelectric point, then the ST segment is elevated there in all of these waves here. The other cause of chest pain with fever is tuberculosis. We've already covered this. Just need to highlight a few things. The diagnosis gold standard is either finding acid alcohol fast bacilli in the sputum or growing it in the Lowenstein-Jensen medium. The Mantoux test would be positive, and remember the Mantoux test is a type 4 delayed hypersensitivity reaction, and the quantiferon test, which has a very high sensitivity and an almost equally high specificity, is a good blood test to do that will tell you whether this patient actively has TB or has latent tuberculosis. There's been recently an increase in the incidence of TB in a number of states in the US, in particular Kansas. And this particular TB that is causing a slight raise in that particular state is multi-drug resistant. So be on the watch out for this if you're going back to practice in the beautiful state of Kansas. Here is what the X-ray looks like. Apical consolidation, white fluffy, with cavities. This happens to be bilateral, and in addition to the apical cavitation with the consolidation, the lymph nodes are enlarged, more prominently seen on the right side, not so prominently seen on the left side. So the findings here in this picture are apical consolidation with cavitations bilaterally and bilateral hilar lymphadenopathy. Any questions? Next, look at the cause of chest pain due to a problem with the chest wall. Remember, this group causes almost 40% of all the chest pain that presents in the primary care setting. Uh, One of the common causes, especially in older people, is herpes zoster. This is a viral infection caused by the HHV3 virus, which is otherwise known as varicella zoster virus. And this occurs primarily in children who had chickenpox as a child and didn't clear the chickenpox virus completely out of the system. It is estimated more than two-thirds of children who have had chickenpox as a child might develop herpes zoster later on in life, because what happens with the uncleared virus, it lays dormant in a nearby dorsal root ganglia. The commonest place it would be in the thoracolumbar region of the sympathetic trunk, and the next common place would be either the trigeminal nerve or the facial nerve. Clinical picture: if it is the virus was dormant in the thoracolumbar region, is a prodrome of chest pain, followed a day or two later by a band of vesicles and pustules along a chest dermatome. And this could be painful. In some people, they develop after the bout of shingles has healed, post-herpetic neuralgia. If this were to affect the trigeminal nerve, it may affect either the ophthalmic division, which is the most common site. Second most common would be maxillary, and then the third most common would be mandibular division of trigeminal nerve. And it presents with, again, a prodrome of facial pain either above the eye, below the eye and the cheek, or along the lower jaw. It could also affect the geniculate ganglia, which is linked to the cranial nerve number 7, facial nerve. And if it does, then this is going to cause typical Bell's palsy associated with painful vesicles in the air on the same side that there is the facial weakness. The combination of Bell's palsy and painful vesicles in the air is Ramsay-Hunt syndrome. No labs are needed to confirm this diagnosis, because the diagnosis is made on the history and the physical exam findings. Refer the patient to a neurologist if within a week of chiropractic care the patient isn't starting to feel a lot better and the vesicles are healing up nicely. The neurologist needs to see that patient within the first 10 days so that if he's going to prescribe a course of acyclovir, an antiretroviral drug that is specific for HHV type 3, or put the patient on a course of steroids, it needs to happen within that first 7 to 10 days to be really effective. Another cause of chest pain that is associated with chest wall problems is a rib fracture. Rib fracture obviously is defined as a break in the rib. The most obvious cause is trauma, but it might not be the trauma you are thinking of. I mean, of course, if somebody hits you with a 4x4 piece of wood and hits you on your chest, you're going to be aware of this. But if you happen to have bony metastases, you go meet a friend that you haven't seen for years, he gives you a great big hug, and next thing you know, you are in feeling intense sticking pain on one side. He has just broken your rib, and that would be an example of a pathological fracture. So the trauma may not be obvious to the patient. The classic presentation of a patient with rib fracture would be pleuritic pain. Remember, pleuritic, the word pleuritic pain means it is sticking chest pain that is worse with taking a deep breath, coughing, or sneezing. This chest pain, which is highly localized, when you ask them, show me where the pain is, they're going to take their index finger and put over that area that where they're feeling the pain, right underneath where the bruise is here. Remember, if the pain is due to myocardial infarction, they're going to put their hand or their clenched fist over the precordium. If this is pericarditis, they're going to put their hand over the uh, pericardium too. They wouldn't use their finger to show you where exactly. When they use their finger, not only are they telling you this is sharp, it is sticking in nature, and this is pleuritic in nature. It is worse with chest compression. With the patient in the supine position, you're going to put your knife hand of your dominant hand on the body of the sternum, and you are going to suddenly push down and towards the shoulder blade. And if this patient had a rib fracture, doing that is going to cause pain. And remember, if you were to have this instruction in part 4 to do a particular test that will confirm the presence of a rib fracture, your performance will be judged on the first thing you're going to do is explain what you are planning to do. Explain that what you might do could cause some pain. Ask for permission before going through the process of ulnar edge on the body of the sternum, pushing down towards the scapula and slightly upwards. You could also use the Shippelman test. Now, the Shippelman test is designed to tell you whether this is muscle strain or sprain, if this is intercostal neuralgia, but could also be used to determine whether there's a rib fracture. Shippelman test, if you remember, hands up at the above your head, and you are going to bend into the place where there is pain. And if you were to do this in a patient with rib fracture, you will cause the broken rib fragments to grate against each other, irritate the nearby intercostal nerve, and leaning into the pain would exaggerate the pain. Chest x-ray will show the obvious rib fracture, either a P to A, or you may need to do a lateral chest view. Refer the patient to the hospital. Let the hospital determine if there is an underlying pneumothorax, how large it is, and whether to treat this or not. So this is what the x-ray of a patient with a rib fracture. There are fractures actually on both sides, the left side and the right side. Let us look at the fracture on the right. Note the smooth outer limit of the thoracic cage. It should be in a nice curve, and there's an indentation right there, and there's a rib fracture right there. If we come over on this side and we follow first rib, second rib, third, fourth, fifth, sixth, there's the disconnect. Seventh, here's a disconnect. So sixth and seventh ribs are obviously fractured here. And again, you see the slight indentation of the normal convex contour of the outer chest. Another cause of chest pain due to chest wall pathology is Tietze syndrome. Tietze syndrome is defined as inflammation of either the second or third costochondral joint. This is associated with repetitive microtrauma, and the clinical picture is a tender, swollen costochondral joint. If the joint is tender and not swollen, and it could be either second, third, fourth, or fifth costochondral joint, then you don't use the term TC syndrome, you use the term costochondritis. It's just, um, you know, it's not a useful clinical separation because you're going to treat them both the same way. No labs are required. You're going to adjust the patient and see if that helps. And if this does not help, refer the patient to an orthopedic surgeon who is going to, one, confirm that this is costochondritis or TC syndrome and inject long-acting steroids directly into the inflamed joint. This has to be done under sterile conditions. If not, you're setting up this patient for the development of an abscess in that area that is going to take some time before it manifests. Any questions? If there are no questions, let's go to the next clinical triad, which is atypical chest pain. And what do I mean when I use the term atypical chest pain? What I mean, the chest pain is not typical of cardiac problems, one. So the chest pain is not squeezing in nature made worse by exertion. Two, it's not typical of pleuritic or pulmonary chest pain, meaning the pain is not sticking in nature, made worse by taking a deep breath or coughing or sneezing. Three, this chest pain is not typical of musculoskeletal chest pain in that it's not sticking in nature and not aggravated by specific movements of the chest wall, whether it would be bending towards the pain or away from the pain, or whether it's associated with sternal compression. So if it is none of those three, sticking or squeezing or related to movements of the chest, then this is going to fit into this category of atypical chest pain. So the first is chest pain associated with gastroesophageal reflux disease, GERD. This is defined as lower esophageal inflammation due to acid reflux from the stomach through an incompetent lower esophageal sphincter. This is seen more commonly in obese patients, or it could be seen in patients with scleroderma affecting the esophageal motility, being part of the CREST syndrome, or a patient with a hiatal hernia, whether it be either congenital or acquired. In this patient, in which the pain is due to the reflux of acid contents and therefore triggered by the presence of hydrogen ions irritating the free nerve endings in the lower end of the esophagus, the patient would classically present with burning retrosternal pain that is worse on lying down or after heavy meals. Uncommonly, patients with GERD may not present with the classic burning retrosternal pain, worse with on lying down and with eating heavy meals. They may present with chronic cough or wheezing that is worse at night. And what happens here, the underlying pathophysiology is they lie down to go to sleep at night. The acid by gravity is going to flow into the esophagus all the way up where it trickles into the trachea. The patient inhales some of that material and is going to trigger a cough or wheezing. And if you have wheezing in an adult and this patient never had asthma as a child, even though you might hear the classic generalized wheezing or bronchial auscultation, think, is this not GERD? And maybe refer the patient to a gastroenterologist rather than a pulmonologist pulmonologist if you think GERD could be the cause of the nocturnal cough or wheezing. The gold standard is endoscopy, visualizing the inflamed lower end of the esophagus and biopsying this. And why do you biopsy this? Patients with chronic GERD, the lower end of the esophagus undergoes a change in the normal stratified squamous epithelium, the simple columnar epithelium that is called metaplasia. When it occurs in the lower end of the esophagus, it is called Barrett's esophagus. And if you remember from trimester 2 and trimester 4, Barrett's esophagus is precancerous or premalignant, and therefore this patient has to be screened on a regular basis to see if the Barrett's esophagus is going to be cleared away. Once you take away the chronic inflammation, the simple columnar epithelium will go back to being stratified squamous epithelium. If left untreated, that Barrett's esophagus will in a couple of years, 10 to 15 years, develop into adenocarcinoma of the lower end of the esophagus. So part of the management of patients with GERD would be referring the patient to the gastroenterologist to have endoscopy and biopsy done. In the meantime, you could be advising the patient to lose weight if they're obese. Raise the head of the bed at least 6 to 8 inches from the horizontal, which will allow gravity to keep the acid stomach contents in the stomach below the diaphragm rather than going into the lower end of the esophagus. Melatonin supplements, 2 5 milligram tablets for 6 weeks, and the Mediterranean diet are acceptable alternative ways of treating GERD without having to undergo treatment on a chronic basis with proton pump inhibitors like omeprazole, which can be linked with a number of unpleasant side effects. And you can tell the patient this. You can say to them, go to the gastroenterologist if he confirms you have GERD and he wants to put you on pills. Ask him, what about melatonin, and what about a trial of going on the Mediterranean diet for approximately 6 weeks, and see if he's amenable to that suggestion. Here is what an X-ray is going to show. I'm going to outline the problem. I'm going to outline the cardiac silhouette, superior vena cava, right atrium, right ventricle, apex of the heart, left ventricle, left atrial appendage, left pulmonary artery, and here is your aortic knuckle. What you have here is superimposed behind the cardiac silhouette is this here, not that, this here. There is a bubble somewhere behind there, and if you can see faintly, there's a horizontal line. If I can find my cursor, there's a horizontal line right there, and that horizontal line has a curve upwards at the two opposite ends. This is the sign of the meniscus. This is a huge hiatal hernia. Here is what is going to clinch the diagnosis if you don't see this on the PTA film. This is the lateral film. This is the cardiac silhouette here. Here is the stomach that has gone up into the chest. And here is the gastric air bubble. The gastric air bubble should have been down here below the diaphragm, but because the stomach has gone into the chest, that gastric air bubble has gone up into the chest and is forming this large air pocket in the retrocardiac position, and that is classic for a large hiatal hernia. This patient, once it is confirmed by the gastroenterologist, will be sent to a cardiothoracic surgeon to help pull the herniated stomach out from the posterior mediastinum and then fix the enlarged esophageal hiatus to prevent this from recurring. The other cause of atypical chest pain is a condition known as mitral valve prolapse. This is defined as a myxomatous degeneration of the mitral valve. The mitral valve is a sheet of fibrous tissue lined on both sides, the left atrial side and the left ventricle side, by endothelial cells. And what happens to the fibrous sheet? It becomes destroyed, and what you're left with is a floppy, gelatinous-like material, so that the valve loses its stiffness. Most of the causes of mitral valve prolapse, when they occur primarily in young female adults, is unknown. If the patient is tall, thin, has spidery, long fingers and toes, that would be Marfan syndrome, in which there's a higher incidence of MVP, mitral valve prolapse. The clinical picture is classic atypical chest pain. So if you were to ask a patient with mitral valve prolapse, tell me about your pain, they may have a scenario that goes like this. Sometimes it is squeezing, and they put their fist over their left chest, and you go, squeezing chest pain, precordial location. This is cardiac pain. But you hear them say sometimes. So you should hear that cue and go, okay. And other times when it's not squeezing, how else is this pain? Well, sometimes it could be burning, or sometimes even sticking. And when it gives you a confusing picture with all three, or maybe two out of the three typical chest pain descriptions, you go, this is atypical. You will then follow your history by examining the cardiovascular system. You're going to place your stethoscope, the bell, or the diaphragm, because it's both you're going to use, in the mitral area. And remember, the mitral area is somewhere in this region here, in the fifth intercostal space on the left side, in the midclavicular line. You put your stethoscope here. And instead of hearing your normal two heart sounds, lub dub, lub dub, lub dub, you are going to hear between the lub and the dub, which is the systole, you're going to hear a click murmur. So lub dub, lub dub, lub dub, lub dub, lub dub, lub dub, lub dub. That's a mid-systolic click. If this mitral valve prolapse gets worse, it is going to give you a full-blown mitral incompetence valve sound. So again, it's going to be between lub and dub, and then you're going to hear a sh sound. So lub shadub, lub shadub, lub shadub, and that is a pansystolic murmur, heard best in the mitral area, which is in the fifth left intercostal space in the left midclavicular line. And you need to know this for parts 2, parts 3, and parts 4. You may get a patient with symptoms and signs of mitral valve prolapse in part 4. The examiner will ask you to auscultate the heart, and when you finish auscultating, your stethoscope with both the diaphragm and then the bell in the second right intercostal space close to the sternum, second left intercostal space close to the sternum, so that would be the aortic, this would be the pulmonary. Fourth left intercostal space near the sternum, that would be tricuspid, and then fifth left intercostal space in the midclavicular line, that would be a mitral. Then the examiner would say to you, you heard a click noise in between the first and the second heart sound. And then you go over into the next room in your post-encounter probe, and they say to you, what is the most likely cause of the murmur you had described to you in your previous encounter? And then you will have to say, this is a mid-systolic apical murmur, classic of mitral valve prolapse. They may then ask you, how is this patient best treated? Co-manage with the cardiologist, because sometimes this murmur, especially if it's associated with chest pain, might be associated with a concomitant subluxation at T4, T5. And if you were to remove that subluxation and allow the NA to do its work, then many times the chest pain will disappear. You haven't cured the murmur. The murmur is still there because of the myxomatous degeneration of the valve leaflet, but at least you have made it asymptomatic. You're going to co-manage with a cardiologist. Most cardiologists these days are just going to watch this every year. They're going to do an echocardiogram to see if this is progressing. And in my days, half of the cardiologists used to put these patients on oral antibiotics for the rest of their lives to prevent this damaged valve from being infected by Streptococcus viridans. That messes with your gut microbiota, gives you gut issues. Cardiologists today no longer put these patients on prophylactic antibiotics. However, they will tell you, if you have to go to a dentist and he needs to do work on your teeth, especially for cavities, let the dentist know you have a history of mitral valve prolapse, and they will know what to do. They have a particular protocol, because if you're going to operate in your mouth, damage the gum, bacteria that might be present in your gum might get into your blood and then latch on to the damaged valve. Also, as you get older, if this is not corrected surgically, because it's a mild prolapse, it hasn't progressed. If you get older and you are in the hospital and you are likely to be catheterized, again, let the doctors, let the medical personnel know you have something wrong with your heart. It's called MVP, and they have a protocol to prevent bacteria from getting through the catheter into your blood. Here is what the echocardiogram, which is the imaging of choice to diagnose mitral valve prolapse. The probe is put on the top of the chest here. What you're seeing here is the left ventricle. This is the left atrium. This is the right atrium. That's the right ventricle. And here is the mitral valve during systole pushing back up into the left atrium. As I said, eventually what might happen is this prolapses to the point where the valve now becomes incompetent and blood will flow from the left ventricle during systole through the incompetent mitral valve into the left atrium, and will give you your classic pansystolic murmur, heard best in the fifth left intercostal space in the mid-clavicular line. Lupsh-dub, lupsh-dub, slupsh-dub. Okay. And then the last cause of atypical chest pain would be a condition first described in the physiotherapy literature back in the 1980s by Maitland and others. T4 syndrome. T4 syndrome is defined as a collection of symptoms related to T4, usually, but it could be either T2 all the way through to T7, not T2 and T3, and it's T2 or T3 or T4 or T5, 6, or 7 hypomobility. It might be associated with trauma. It might be associated with bad posture. It is more common in females than males. It's more common in females that have large mammary appendages. Clinical picture, vague chest pain. You know, they're going to wave their hands around. Their hands are not going to go over any part of the chest. It's not going to clench. It's not going to use their finger. It's a strange chest pain, doc. There might be paresthesia in the hands. There might be headaches. There might be shortness of breath. And what is the diagnostic marker as such? If you were to spring, so you're going to put the patient in the prone position, put your pisiform bone on the vertebra that is hypomobile, and suddenly push from the P to A direction towards the sternum with the patient in the prone position. If that precipitates the pain, or if they say, I can feel the tingling in my fingers, or my headache just got worse, then yes, you have T4 syndrome. No labs are necessary. The diagnosis is made on the history and the physical examination, springing the hypomobile vertebra. Management would include chiropractic adjustment, heat modalities to reduce the inflammation around the area, and advice on posture. Straighten up your chest, push your chest out, shoulders back, and this might have to be on a recurrent basis. So that is T4 syndrome. Here is the original paper by Maitland in 1986. Actually, it was written in German and then translated, and then similar year written in a book called A Modern Manual Therapy for the Vertebral Column by McGuckin. And then later on, almost 10 years later, Franca and Levine published the first article in the chiropractic literature, because this is treated the same by both physical therapists and chiropractors. The physical therapist would do the same spinal manipulation. Chiropractors would do the chiropractic adjustment. If you understand that a chiropractic adjustment is more specific than spinal manipulative thrust. And then you're going to, both professions will work on the posture and advice, and may or may not use modalities. Any questions? The next hub is the patient has chest pain, but the history, I didn't really get the proper history, and it could happen that the patient's description of their chest pain is not really clear. The physical examinations might be not obvious, and you will then need to let me take a chest x-ray to see exactly what is going on. So um, the next three diseases, I will show you the x-ray, and then we're going to interpret the x-ray, and from the x-ray come up with, oh, that's the cause of your chest pain. So here is the first. And if the findings are not obvious, then you're going to go through what you learned with your radiology teaches here, the A, B, C, D, E's of reading a chest x-ray. A would be airway and alignment, B would be bony tissue, C would be the cardiac silhouette, D would be the domes of the diaphragm, and E would be everything else. So if we started off with A, alignment of the trachea. The spinous processes are right here, and it looks as if it's central. Here's the right, here's the left. We now look at the lung fields. We come over here, we see on this side the bronchopulmonary markings, these faint grayish whitish streaks go almost all the way out to the periphery. We come over here and we see there's something going on here. And wait, oh, there it is. There is the outline of the partially deflated lung. So this is why the physical examination findings of a pneumothorax might not have been obvious in this patient. Lung air still comes in there. The tactile fremitus and vocal resonance might have been slightly reduced, but breath sounds are present. Percussion note appears to be normal. And then you go, okay, X-ray clinches the diagnosis. This is pneumothorax, which we've done already. And remember, with the pneumothorax, you're looking for increased percussion note. You're looking for collapsed lung on the X-ray. You're looking for a deviation of the trachea. And if we went back in our mind, because I can go back using this particular form of the presentation, the trachea was not displaced, it was in the middle, and therefore this was not a tension pneumothorax, this was an ordinary pneumothorax. So we're not calling 911, we're just referring the patient to the hospital for the hospitalist to determine, are they going to put in an underwater intercostal tube to drain the air out, or are they just going to allow the body to heal itself naturally and resorb the air because it's not getting larger? Here is the next X-ray. We took a chest X-ray. We looked at the PTA. We looked at the lateral, and we saw something going on in the thoracolumbar region. Here is this vertebra that is wedge shaped. The anterior border has collapsed. The other nearby vertebra are washed out. They are very faint trabeculae. This happens to be a 73-year-old white woman who was not aware that she had undergone any accident as such. And when you say to her, you have one of your vertebral bodies collapsed, you have osteoporosis, because this is the collapsed vertebra associated with osteoporosis, and you say to her, did you ever kind of misstep coming down the stairs, didn't quite fall, or stepped off the curb, was not paying attention and landed kind of awkwardly on your heel, just jammed like that, and then felt the pain afterwards? Yeah, that trivial injury would have been enough to cause axial compression and cause this compression fracture of your vertebra. So that's the diagnosis: compression thoracic fracture, defined as a compression fracture of the thoracic vertebral body. It could be one of two things: osteoporosis, which is obviously going to be common in an older white female, or it could be metastases. The patient might have had prostate cancer unbeknownst to him or you spread to the bone and then cause the pathological fracture. The patient might have had a breast mass that um, was malignant, didn't raise any red flags, spread via the hematogenous route, or some other internal cancer. Clinical picture: sudden onset of sticking chest pain after trivial trauma, or it could be something innocuous as a coughing fit. And the cough causes compression of the anterior portion of the osteoporotic vertebra. Sometimes it might be associated with a gibbus. A gibbus is a prominent spinous process due to marked angulation of the compression fracture. Labs should include a lateral thoracic spine, which will show the classic wedge-shaped vertebra that is affected, and the surrounding vertebrae are osteoporotic in nature. Should you suspect a compression fracture as the cause of chest pain, refer the patient to the hospital or maybe to an orthopedic surgeon for them to determine if vertebroplasty or some other surgical intervention is warranted or not. And here is another scenario. This is a 36-year-old African American female, and that should be jogging some memory cells somewhere in your hippocampus. African American female with chest pain, slight shortness of breath, but didn't really put the two together that this has been going on for months, so this is a chronic problem. You take the chest x-ray and you see these large swollen lymph nodes in the hilar region. So the finding here from a radiological perspective is bilateral hilar lymphadenopathy. Now that you are going to put bilateral hilar lymphadenopathy together with African American female in the 30s or 40s, you should come up with what diagnosis? Sarcoidosis. Yes, we've covered sarcoidosis before. Remember, this is more common in black middle-aged female. The cause is unknown. In addition to the chest pain, they may complain of shortness of breath, which may be associated with exertion, fatigue. They may have these darkish reddish brown spots on the anterior aspect of the legs. This is called erythema nodosum. Occasionally, they may have inflammation of the iris. They may have a splenomegaly, or they may have internally lymphadenopathy. And remember, the combination of leukopenia and hypercalcemia is indicative of sarcoidosis. Co-manage with a pulmonologist who will then find ways to confirm the diagnosis, either biopsying the erythema nodosum or biopsying one of the nodes in the lung via the trachea or bronchus, transbronchial lymph node biopsy, and they'll be looking for chronic inflammation, which would be lymphocytes, epithelioid cells, and fibroblasts, and with non-caseous necrosis. Now remember that sarcoidosis is just one of a probably handful of causes of bilateral lymphadenopathy. So what should be included in this differential? Anytime you mention the term sarcoidosis, in your differential must be tuberculosis. Tuberculosis, if it is going to be presenting with bilateral consolidation and cavitations, will have bilateral hilar lymphadenopathy. It could be a patient with Hodgkin's lymphoma, in which the enlarged lymph nodes, once you biopsy this, the histopathologist will see the classic Reed-Sternberg cells that would be classic for Hodgkin's lymphoma. And fourthly, if you had lung cancer spreading to the lymph nodes, it's usually going to be unilateral. But if you had metastases to both lungs and both hilar lymph nodes are going to be involved, then the histopathologist may say, there is prostatic cells, malignant prostatic cells in the lymph node biopsy, or malignant breast cells or malignant stomach cells in the lymph node biopsy. So sarcoidosis, tuberculosis, Hodgkin's lymphoma, and lymph node metastases involving cancer. Any questions? Okay, so let's look at the laboratory tests from a summary perspective of the labs that we ordered when discussing these diseases. We talked about infections and we talked about sarcoidosis. So if this is an underlying infection, CBC is needed to be ordered. And if this were a bacterial infection causing a pneumonia, then you're looking for leukocytosis and neutrophilia. If it were a viral infection, then you're looking for leukocytosis and a lymphocytosis. If the patient presented with chest pain and or shortness of breath and bilateral hilar lymphadenopathy, the CBC is going to classically show leukopenia. Comprehensive metabolic panel, again, we're thinking of sarcoidosis. We're looking specifically at the electrolyte part of the comprehensive metabolic panel and looking specifically for hypercalcemia. And if hypercalcemia is present, together with leukopenia in the complete blood count, tells you this is sarcoidosis. D-dimer was a good test to order if you suspected the patient with acute onset of shortness of breath, hemoptysis, and pleuritic pain, that this could be a pulmonary embolus from a deep vein thrombosis. The D-dimer is a good screening test. As a good screening test, it means if the test result is negative, you can rule out that this is a pulmonary embolism caused by DVT. It could be a pulmonary embolism, as I said before, caused by either air embolism, fat embolism, or amniotic fluid embolism. So for a DVT-PE, which is a pulmonary embolus caused by a deep vein thrombosis, whether it's in the leg or the pelvic region, the D-dimer has a very high sensitivity, 95%, but a low specificity. And because of its high sensitivity, it's a good test to exclude DVT-PE if the test result is negative. But it's not a good test to confirm the diagnosis of a DVT-PE. The MAN2 test is a skin test in which you use purified protein derivative from the tuberculous bacilli injected into the skin intradermal. And you remember you're going to read this 48 to 72 hours later, because this is an example of a type 4 delayed hypersensitivity reaction. And what you are measuring is not the area of redness, but you're measuring the area of induration. And remember, induration means firmness, and if it is greater than 15 millimeters, it's a positive test. A positive test does not mean you have TB. A positive test means you have been exposed to the tuberculous bacillus sometime in the past. So it may mean You have been given BCG vaccine as a child if you're coming from developing countries and migrating to the United States, or you have, as an American, lived abroad in Pakistan or some parts of Africa or Central America or South America or the Philippines or in the Pacific Islands, contracted TB, and you've had TB in the past, or you currently have tuberculosis. Any questions? Okay, so let's finish this up and look at a number of physical signs or tests that we talked about during our discussion related to chest pain, whether it be related to chest pain and fever, chest pain and shortness of breath, chest pain and particular x-rays, etc., etc. So the first we had looked at was listening for the murmur associated with mitral valve prolapse. You are going to be tested in the next examination. I will give you a clinical vignette where a patient has a particular murmur in a particular area, and I'll tell you whether this is a diastolic murmur or a systolic murmur, and I will ask you which of the following is most likely to be affected. Is it the aortic valve, mitral valve, pulmonary valve, or the tricuspid valve? Remember that these areas of auscultation, when you hear the heart sounds lub dub, lub dub, lub dub, it's the closure of the valves. And if you hear the lub dub over this area, second right intercostal space, close to the body of the sternum, that's the aortic area. Second left intercostal space, close to the sternum. Uh, the books may call close to the sternum as parasternal. Second left intercostal space, that is the pulmonary area. Fourth left intercostal space parasternally, tricuspid area. Fifth left intercostal space in or within the midclavicular line, that's the mitral area. So if you hear a murmur that is heard best in one of these, then if it is heard best in this area, it's more likely to be an aortic murmur. If it is heard best in this area, it's more likely to be a mitral murmur. These are the most common murmurs that are associated with adults, aortic and mitral. Next would be pulmonary and tricuspid. Then, having been told there is a murmur heard best in one of these four areas, you're going to have to determine, is this um, mitral incompetence or aortic stenosis or whatever combination. And for that, you're going to need to remember that here are the following valves that are going to give you, if they are having a problem, they're going to give you a diastolic murmur, or if they are going to give you a systolic murmur. Remember, a systolic murmur is going to occur between the first and the second heart sounds, lub dub, sh dub, sh dub, or it's going to be between the dub and, which is the second heart sound, and the first heart sound. So here's the normal two heart sounds, lub dub, lub dub, lub dub. I'm going to insert now a diastolic murmur, and that diastolic murmur is going to come between dub and the lub. Lub dub, sh, lub dub, sh, lub dub, sh, lub dub. Sorry. So you have a mnemonic that you learned for part one. You're going to bring that knowledge forward into parts 2, 3, and 4. And here are the diastolic murmurs, heard best between the second and the first heart sound, and the mnemonic is arms and parts. The AR in the arm stands for aortic regurgitation. The MS stands for mitral stenosis. The PR is for pulmonary regurgitation or incompetence. Incompetence is the same as regurgitation, and the TS would be for tricuspid stenosis. And all of them are going to sound similarly between the second and the first, between the second and the first, between the second and the first, between the second and the first. But these two down at the bottom here um, have a different name. I'm not too sure whether your teacher taught you about these murmurs that are loud to start off with and get softer and then disappear. This is called a decrescendo murmur. And this one that starts off loud disappears and then starts off again and becomes louder as it gets closer to the first heart sound. This is a decrescendo crescendo murmur. I never paid attention to any of these as a medical student because I knew I'd been tested earlier in my life and I found out that I had problems hearing low pitched sounds. And therefore, I all I knew was if I hear a murmur as a primary care physician, it is not my business to say this is a murmur of mitral incompetence or tricuspid stenosis. I go, this is not normal. I'm sending you off to a cardiologist, and I recommend you do the same. So if it is not a diastolic murmur involving these four valves, then it must be a systolic murmur. So here are the systolic murmurs between first and second heart sound. So if you look at aortic stenosis and pulmonary stenosis, you have your classic crescendo, decrescendo, crescendo, decrescendo. And here is your mitral valve prolapse, your mid-systolic click, and then there is a late diastolic murmur. These two, mitral regurgitation or incompetence, tricuspid regurgitation or incompetence, or a VSD, the noise is heard at the same level equally between first heart sound and second heart sound. And the word they use for this is, there are two terms, pansystolic or holosystolic. As I said, I doubt whether you're going to get these descriptions in your boards to go. There's a pansystolic murmur heard best in the fourth left intercostal space parasternally. Which of the four valve problems is this more likely to be? They're unlikely to give you both tricuspid incompetence and tricuspid stenosis. If the murmur is heard best in the diastolic phase in the fourth left intercostal space parasternally, it is going to be one of the four that we've just discussed. Okay. Next is diagonal earlobe crease. We didn't actually mention this, but this is a good marker. It's known as Frank's sign. And this diagonal earlobe crease goes from the intertragus. Intertragus is the gap there, backwards towards the edge of the earlobe. It may indicate a risk of having a heart attack in the future. Or if you see this in an older person, you can say to them, have you had heart problems in the past? And he says, yes, doc, I had a heart attack 2 years ago. How I haven't said anything to you. How do you know that? Oh, I saw this telltale sign in your earlobe. The mechanism is unknown. The sensitivity, specificity, not all that great. So if it is present, it could mean, and therefore what I would use this to do is, if you've not had a history of a myocardial infarction in the past, I'm going to check your blood pressure. I'm going to order a lipid panel. I'm going to look at your cholesterol level. I'm going to look specifically at your low density lipoprotein levels. And if that is elevated, I'm going to say to you, you have a couple of risk factors. You're a male. You're over the age of 60. You have this marker in your ear, and you are overweight, and you are smoking. So can we do something to reduce the risk of your dying suddenly and making your wife an early widow and not enjoying spending time with your grandchildren as they grow older. Finger clubbing. Finger clubbing, also known as Hippocratic fingers. There's the bulbous swelling of the fingertips and fingernails. There's a space called Shamrot space, and Shamrot space. So this is the bulbous swelling of the terminal phalanges, including the fingertips and the fingernails. And here is Shamrot space. If you were to put the middle fingers of each hand together like that, you should see a small diamond-shaped area. If that diamond-shaped area disappears because of the bulging of the curvature of the fingernails, then a decreased Shamrot space is indicative of clubbing. If this is seen in children with cyanosis of the fingertips and toes and tongue and lips, this is indicative of Fallot's tetralogy, the most common cause of congenital cyanotic heart disease. In an adult, if the patient presents with chest pain, shortness of breath, fever, it could be the patient had a pneumonia. The pneumonia is complicated by a lung abscess, which is classic for Staph aureus or Klebsiella pneumonia in alcoholics. They are prone to lung abscesses. You could have finger clubbing developing. Subacute bacterial endocarditis, which is, we haven't discussed this specifically, but we talked about this tangentially when we discuss mitral valve prolapse, that the prolapse damaged valve is prone to bacterial infection sometime in the future. It is often associated with strep viridans, which is associated with dental caries, and then you're going to get subacute bacterial endocarditis. Clubbing, finger clubbing is one of the features. And then one of the obscure causes of finger clubbing that have nothing to do with the heart or the lungs is cirrhosis of the liver. So if you see this and you examine the cardiorespiratory system and you didn't find anything abnormal, shift your examination to the abdomen looking for a hard, palpable, enlarged liver erythema, palmar erythema, spider nevi, caput medusae as features of cirrhosis and or the presence of ascites. Levine sign, we didn't quite talk about this. I said sometimes patients will hold the clenched fist over the left side of the chest or over the sternum. This is called Levine sign after the American doctor Samuel Levine, who first described this many years ago. And Dr. Levine said he was willing to put money down that anytime he asked a patient in his cardiac ward, tell me about your chest pain, and before they could explain with their words that my chest pain when it started was squeezing in nature and is over my heart, their right hand is clenched in a fist held over either the sternum or the left side of the chest. And Sam Levine says, I will put money down that when we do the ECG, we will find signs indicative of a myocardial infarction. And two, when we send blood for cardiac enzymes, the troponin is going to come back elevated, the CKMB is going to come back elevated, and so is the lactic acid dehydrogenase. And this would be a expression of Sutton's law, where you're willing to put money down that the presence of these is indicative of this particular disease. It has a relatively high specificity, 90%. Therefore, if it is positive, if Levine sign is present, then the patient has a 90% chance of having a myocardial infarction. Its sensitivity is 40%. So if it is not present, it doesn't say you can't have myocardial infarction. Here's your Shippelman test. Arms above the head. Ask the patient to bend towards the side, either with the pain or opposite the pain. It doesn't matter. Same side pain. Bending to the same side causes pain, rib fracture, or herpes zoster, postherpetic neuralgia. Opposite side causes, so bending away from the side of the pain causes the tissue there to be stretched. That is indicative of muscle strain. This test, as I say, is not specific for rib fracture or herpes zoster postherpetic neuralgia, but could be used to help you solidify that my diagnosis is a rib fracture or herpes zoster. Splinter hemorrhages, once again, we had mentioned tangentially the possibility of subacute bacterial endocarditis complicating mitral valve prolapse. It could present with vague chest pain, a mild fever. Splinter hemorrhages are described as small linear streaks underneath the nail bed running parallel to the growth of the fingernail. It is seen classically in subacute bacterial endocarditis, but is not pathognomonic because repetitive trauma and psoriasis will give you similar splinter hemorrhages. But if you see this in a patient with fever and chest pain, you should be examining the cardiorespiratory system, looking specifically for heart murmurs. Sternal compression, downward movement of your hands placed on the body of the sternum. If when you do that, it causes the patient to wince with pain, and if they had a history of trauma to the region, then the diagnosis of rib fracture is confirmed from a clinical perspective. And then there's titubation. We talked about murmurs. There's a particular murmur called aortic incompetence, which will cause every time the heart beats and 70 cc's of blood rushes out of the left ventricle into the aorta, and the valve does not close, and half of that 70 cc's rushes back down into the left ventricle. You're going to have this rhythmical nodding of the head. This is called titubation. And this is nodding in the sagittal plane. Two diseases can cause this: cerebellar disease or aortic incompetence. Since we're dealing with chest pain, you're going to learn aortic incompetence is the cause of titubation. And if you are going to get a similar question in the neuromuscular skeletal part of part 2, they're more likely asking you about cerebellar dysfunction causing this nodding, as if you're saying, yes, I understand. The difference between the two is in the rhythm. In titubation associated with aortic incompetence, and the sign is called de Musset's sign, the rhythm of the nodding matches with the radial pulse. Boop, 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 boop. Beating with the heart, that's about 60 beats per minute. That is de Musset's sign, which is indicative of aortic incompetence. If it does not match, if the rhythm does not match the rhythm of the radial pulse, it is either faster or slower, then it's more likely to be cerebellar disease. And then you can go, okay, if this is cerebellar disease, what could I do? I could ask the patient to alternately rapidly touch the back of the hand with the opposite hand and do that back and forth, back and forth. And if they can't do that regularly, then they'll be suffering from something called dysdiadochokinesia, which is an expression of cerebellar dysfunction. Another test that you could be asked to follow dysdiadochokinesia is the pass pointing, and we did these two already. Previously, you asked the patient to touch their nose and touch your finger, move your finger to the side, touch their nose, touch their finger, and if they miss either their nose or your finger, this is called pass pointing or dysmetria, then it's evidence of cerebellar disease. The other cerebellar dysfunction test, patient in the supine position, you're going to ask them to take off their shoes. They could be with their socks, and they're going to take the heel of the right foot and run it along the anterior border of the left leg, so their left shin, up and down, and then you're going to ask them to switch and take the heel of the left foot and run it down between the knee and the ankle. And if they were having cerebellar dysfunction, they wouldn't be able to do that smoothly. They would kind of fall off the shin as they're trying to keep on the shin. The other thing you could do is have them walk the white line. You don't have to take them out on the road. You can put a tape on the ground and have them walk heel to toe on that line. And if they had cerebellar dysfunction, they would not be able to keep their balance. Remember, the Romberg test is not a test for cerebellar dysfunction. The Romberg test, developed by Dr. Johann Romberg way back in the 19th century, is a test for dorsal column, medial lemniscal pathway pathology, either tabes dorsalis, secondary to tertiary syphilis, or dorsal column pathology seen in vitamin B12 deficiency causing posterolateral disease. I know some of you might have taken away from learning neurological examination that you do the Romberg, and the Romberg test is a test for cerebellar dysfunction. It is not. Let me remind you, to do the Romberg test, you need to have the patient do three things before you can say, yeah, the Romberg sign is positive or negative, absent or present. And here are the three things. You say to the patient, you're going to stand to the side, slightly to the back. You're going to say to the patient, I need you to stand with your heels together. Yep. Now I need you to stand with your arms by your side. Yep. Now I'm going to ask you to close your eyes. And when they do have completed all three steps, they start to sway, whether to the side or back to the front, and you were going to catch them to stabilize them, prevent them from falling. That is a positive Romberg sign or test. If you start to do the Romberg test and you say to the patient, put your heels together, and as they do that, they start to become unsteady. They put their hands out straight on either side of them, and as if to balance themselves, like the tightrope walker. People would use the long poles to stabilize their balance on the tight wire act. They have not completed all three steps for you to say that this is Romberg positive. It will say to you, okay, I can't do the Romberg test on you. I notice that you probably have signs of cerebellar dysfunction. So let's do the rapid alternating movements to see if you have dysdiadochokinesia. Let's do the pass pointing. Let's do the the heel on the shin test. And if you have those, then you go, oh yeah, you have cerebellar dysfunction. Is that clear? Any questions? Here is the homework for next week. We will be doing abdominal pain. We will be tackling a fair amount of diseases. I think there are 28 diseases we will cover next week. And on the final hour, we will come back and review the labs and review the physical exam findings before, if we have time, play the game of 20 questions, think aloud. Because you didn't have a hell of a lot of diseases to do in this particular week, when you come back and I see you in the final hour, we will have time to play the 20 question think aloud game for 5 bonus points. Okay. Any questions? I will see you guys later.